Good afternoon, everyone, and welcome to the Thursday afternoon Cholangiocarcinoma Foundation webinar series. I am Melinda Bikini. I'm the Chief Patient Officer with the Foundation. I'm also a 15-year survivor of stage 4 cholangiocarcinoma, and we are excited to be joined by Dr. Coy today. Dr. Eugene Coy is a professor of gastrointestinal radiation oncology at the University of Texas MD Anderson Cancer Center. He specializes in the treatment of patients with liver and pancreatic cancers and has published a series of studies on the use of high doses of radiation therapy to improve outcomes for patients with these highly lethal malignancies. His team strives to incorporate advanced technologies to deliver high doses of radiation safely to these sensitive areas of the body while developing quantitative methods to identify the patients who are most likely to benefit from these treatments. We will open the webinar to Dr. Coy, and we can ask you guys to put any questions that you have in the chat or the Q&A box. And after the presentation, as always, we will get to them. And a reminder again to just keep those questions general in nature, as we won't be able to answer any personal medical or give personal medical advice. So Dr. Coy, thank you for joining us, and I will turn it over to you.
Thank you, Melinda. I really appreciate the introduction and the opportunity to share this presentation with everyone online and who watched the recording. So thank you all for taking the time to hear us about radiation therapy and how this might possibly improve outcomes for patients with intrahepatic cholangiocarcinoma. So I want to first start off by just giving a special thanks to the Cholangiocarcinoma Foundation. I mean, you guys are fantastic to work with and, just do so much for both the patients as well as the physicians to educate and, bring things, closer to the heart and, just make such a major impact. So thank you for what you guys do, as well as our patients. I mean, a lot of this research would not be possible without them participating in clinical trials and allowing us to look at their imaging, their tissue, their blood, to make strides to move things forward for the next cohort of patients that have this disease and make things better. So thank you all. I want to start by just sharing a anecdotal case of a patient that I treated in years past. She was 50 years old. She presented to her local physician with abdominal pain. They did a CT scan initially, and then eventually this PET scan, which I'm showing here. And it showed an 11.9 centimeter mass in the liver. And the biopsy showed invasive, poorly differentiated adenocarcinoma. They couldn't find any other source of adenocarcinoma in her body, and came to the conclusion that this was an intrahepatic cholangiocarcinoma. She started off with first-line treatment with Y90. So this was yttrium 90 or SIRT, or TARE as might be called out in the community, where they're injecting radioactive beads through the artery of the liver's arterial blood source to try to treat the cancer internally with radiation. After that Y90 at this outside hospital, she received 8 cycles of gemcitabine cisplatin chemotherapy. This was about 3 or 4 years ago now, prior to the era of immunotherapy with chemotherapy that has recently become the standard of care. So this was how she was treated. And then 1 year later, after she had received all that therapy, she developed this recurrence as shown in the PET scan, where there was active disease at the periphery of her tumor inside the liver. And then she also developed a left supraclavicular node just here below the neck. And they biopsied that, both sites, and they identified that she had an FGFR gene fusion. And she did start to get that therapy. But first, before she began that, drug inhibitor therapy, which, some of our medical oncologists, that are involved with CCF as well as other things, they demonstrated that that could, really significantly benefit patients and, has led to FDA approvals, which is a major, thing. But in addition to that, they referred the patient to me to consider doing some radiation therapy to the liver, even though she had disease outside the liver, in that lymph node, near the neck, which was not standard. And it remains, not standard, in clinical practice outside of MD Anderson. And we considered it because we're thinking, okay, this is a large liver tumor, and this might cause problems for her in the future. And so we designed this radiation plan that I'm showing here. These are all the different dose levels of radiation that are colored here in the right side panel. My prescription dose was 6,000 centigrade, or converted to our usual units is 60 gray. And we delivered that over the course of a couple of weeks. And we're focusing that radiation, primarily on the large liver tumor. I also, in this case, did treat her lymph node, and she tolerated it, as we would expect. She had some fatigue, she had a little bit of nausea, but all those, got better after a few weeks, after the radiation. And now she's over 3 years out. She's still alive and well. She did take the FGFR inhibitor subsequent to the radiation, and then had one recurrence in the liver outside of the radiation field. And that was ablated with a microwave ablation technique last year in 2024. And she's come back for follow-up and is alive and well and doing great. So this is one, anecdotal success story. This is kind of the example of the types of patients that we're interested in seeing, whether we can benefit, the wider, less selected type of patients, in clinical trial settings. And I'll get to that kind of evidence in just a few slides. But first, I want to just, kind of educate the group about, the technological advancements with radiation or RT. This has come a long way over the past couple of decades. We've been very fortunate, at the start of my career, which was in 2014, starting as faculty here, kind of riding the coattails of, innovations that other innovators in radiation and physics, developed, in the preceding, years and decades on motion management, where we can have the patient hold their breath, his or her breath during the radiation treatment for about 10 to 15 seconds at a time so that we don't have a moving target while the radiation beam is on. You can also do this using a gating technique, which is basically tracking the tumor as it's moving while the patient is breathing, but only treating and turning on the beam whenever the tumor is in a certain window where the beam is aiming. So that's another technique that you could use. And there's also something called surface guidance. So we can actually constantly monitor the surface of the belly or, the chest wall or whatever we're trying to treat and make sure that kind of convexity or the surface of the, patient's abdomen or, chest, is, the same as whenever we, design the radiation field. And there, in that sense, we know that everything is in alignment with where the radiation is targeting. So all these motion management techniques are new innovations that have come online in the recent years and have helped us to deliver very focal radiation doses as shown here. There's also other image guidance systems, high resolution cone beam CTs. Previously in the previous era of cone beam CTs, these were very fuzzy images where you can't make heads or tails about what is what. But now with the newer systems, they're almost CT quality as shown here. These are not cone beams, but whenever you take these high resolution cone beams, they look actually quite similar to the diagnostic CTs that we have pictured on this image. There's also CT on rails images as well as MRI linear accelerators where we can get even better quality images to see what does the anatomy look like on a day-to-day basis while the patient's in the treatment position in the radiation room, knowing what's going on internally, which we otherwise wouldn't have any way of knowing. So these are all things that allow us to ensure that the radiation field that we designed will ensure that that's covering the target and not hitting other targets like the stomach or the bowel or any other critical normal tissue structures or organs that we don't want to damage with the radiation. We have adaptive radiotherapy systems online now too. So these are AI enhanced. They can very rapidly turn around a new radiation plan while the patient's laying there on the table within a few minutes, and then deliver a customized radiation plan for that patient's anatomy at that moment. So these are brand new systems and things that are really going to really change the way we practice radiation going forward. There's also biological guidance. So we actually can inject tracers, that target the tumors and allow us to target the radiation to those active areas that the tumors are revealing themselves to be. Conformal delivery is something that we've been working on for decades as well. So there's protons, there's stereotactic techniques. There's also something called volumetric modulated arc therapy. These are all ways to just kind of form this very conformal radiation dose cloud where this high dose is, aiming at that target and trying to spare all the surrounding normal tissues as pictured in these different images that I've shown here. So here are two examples of proton plans where there's no exit dose with the protons, and that's beneficial, especially for patients with right-sided tumors, because you can come in from just a couple of angles to spare all the rest of the body from radiation exposure. Central tumors and tumors on the left, you can use protons there, but we can also use very nice conformal radiation treatments using stereotactic techniques and VMAT. And so those are pictured here. So these are all the different technologies that have come online in recent years that have enabled us to achieve some of the results that I'm about to show you. So before we get into that, the one other thing I wanted to kind of emphasize is the reasoning behind, giving even a high dose of radiation. I mean, we could potentially get away with lower doses more safely. And the reason is that we looked at this, from our own data at MD Anderson over the course of 2002 until 2014. And we found that the vast majority of patients, 83% of them with unresectable intrahepatic cholangiocarcinoma, or what we're calling advanced iCCA, 83% of them have either biliary or vascular problems related to their tumor that results in death of that patient. This is a very high percentage. 4 out of 5, or over 4 out of 5 patients will have biliary or vascular complications in the liver related to their primary tumor, even if they have disease outside the liver. This is the primary cause of death, and this often happens within a year. Speaking to the need to be able to control those liver tumors so that we can reduce the risk of this happening. Okay. So improving local control in the liver could potentially significantly prolong survival of these patients and their quality of life, because then they don't need as many interventions or antibiotics or pain medications for that matter. So these all remain ideas, hypotheses that we need to test and prove or support with data. Okay. So we started looking at this. First of all, what is the pattern of care within the USA? We looked into this National Cancer Database, the NCDB. This is a database that has been developed amongst multiple states and institutions across the U.S. And we searched between 2004 and 2018 and found 37,000 patients or so who had intrahepatic bile duct malignancies. We were focusing on unresectable cholangiocarcinoma because this is primarily the patient population where, radiation would be used rather than surgery, for example. And we nailed it down to patients who just got chemotherapy and those who got chemotherapy and liver-directed radiation therapy. And so those numbers were 1,181 and 2,374. And then amongst those patients who got radiation, we looked at those who got what we call a BED, or biological equivalent dose, less than 80.5 gray or greater than or equal to 80.5 gray, which we considered to be a threshold for what we would classify as ablative radiation. And that's related to some other data that I'll show you in just a moment. That threshold basically associates with better control of those liver tumors whenever you reach that threshold. So that's what we defined as ablative. And we found that over those years that we looked at these patients, there were 303 or 27% of these patients that got radiation over the years who met that threshold. Okay. And we looked at this on a regional basis and over time. And the take-home points here are that in figure A, okay, this is from 2004 to 2018, the rate of utilization of radiation therapy for the entire cohort of patients that we studied, with unresectable intrahepatic cholangio, remained kind of constant, around 15% or so, somewhere between 10 and 20%. It kind of, oscillated a little bit, but it really has not significantly increased over that almost 2-decade time span. On the other hand, if you look at the use of ablative radiation therapy, meeting that threshold of 80.5 gray BED, that has, had an upward trend, where about 50% of patients are now getting, ablative radiation doses, as of 2018. Interestingly, if you look at the patterns across the US, there are some hotspots where radiation is used in general, and that changes over those time periods that are shown here. The use of ablative radiation therapy has increased, particularly in Texas, largely, because of MD Anderson and, other institutions that, use the radiation techniques that I talked about. But other institutions in other parts of the country are not so high of utilization, despite the emerging evidence that I'm going to show you. So these patterns of care really emphasize the disparity and the knowledge gaps that exist with regards to radiation therapy across the USA. And we expect that this would probably be seen, in the rest of the world as well, with the USA just being, one example of that. And this is reflected somewhat in the current NCCN guidelines. If we focus on patients with unresectable intrahepatic cholangiocarcinoma, these are the options for primary treatment. If you get diagnosed, what is the first thing that your oncologist will give you? And by and large, everybody agrees systemic therapy is probably the first line therapy that should be offered, or a clinical trial. Okay. A combination of chemo and chemoradiation, has all these little superscripts here. And basically, those are speaking to, the need for more evidence and, selection of patients, who would benefit, after a multidisciplinary discussion. But this is not the first option, as you can see. Other local regional therapies like the Y90 that we talked about for that first patient, and, transplant are also things that are considered, okay? Now, if you get to the more advanced disease population, metastatic disease, so this is intrahepatic cholangio where it's gone outside of the liver, the options remain similar. Systemic therapy, clinical trial, which is preferred, okay, for both of those. And the consideration of local regional therapy, these are not things that are as emphasized as implied by these preferred in parentheses things, okay? So this is where the current guidelines are, and what we're trying to do with this presentation is present to you the role of radiation potentially, and see where can we go to strengthen these guidelines. And the answer is we need more randomized controlled trials. An example of what that looks like is shown here. Okay, so you have a patient who's diagnosed with intrahepatic cholangiocarcinoma or whatever diseases of interest. They may get some treatment, they may not get any treatment, and they might just go straight to the clinical trial. But there is allowance for potentially some treatment beforehand. Oftentimes with diseases, especially with intrahepatic cholangiocarcinoma, we know that about 40 or so percent of patients have targetable mutations, and those patients have a different prognosis than the other patients who do not have targetable mutations. So you need to find some balance in these prognostic factors that allow you to make sure that there's balance in the experimental treatment arm or the standard of care treatment arm. Okay. So, in one instance, you might test the role of radiation with, the standard of care chemotherapy and immunotherapy as arm one. And in another instance, the arm two would be the standard of care of just chemotherapy and immunotherapy. And then after that, you measure the effectiveness of the two different arms, okay? And once enough measurements of effectiveness have been made, you can ask the question, which arm did better, okay? So we've seen good examples of that in recent times with gemcitabine, cisplatin, and durvalumab, as well as gemcitabine, cisplatin, and pembrolizumab. So two different chemoimmunotherapy regimens have shown consistent results in recent years, 2022 and 2023 were the initial reports of these randomized controlled trials in comparison to a placebo with gemcitabine and cisplatin. In both instances, the addition of immunotherapy led to a significant, clinically significant, and statistically significant benefit in terms of overall survival of patients. So these are what changed the standard of care. Now, that's just an example with drug-based therapy. Where are we with regards to, say, local regional therapies like radiation? Unfortunately, we're not at the same level of evidence. And this was one example. Unfortunately, with GI-001, this was a randomized phase 3 study of focal radiation therapy for patients with unresectable localized intrahepatic cholangiocarcinoma. And as you can see, the date 2014. Okay. This was the stratification, tumor size, satellite lesions. They were randomized to radiation with the chemotherapy standard at the time, which was gemcitabine cisplatin in 2014, versus gemcitabine cisplatin alone. The outcome of this, unfortunately, after about a year, was that it was terminated as a clinical trial. Um, Unfortunately, no patients enrolled. There were many challenges, and I'm just listing a couple of them here. There there were very strict inclusion criteria. I was involved in the study, as the site PI for MD Anderson, and it was a national, cooperative group trial. They were quite strict in the entrance into this study, making it very challenging to enroll patients, based on that. And then whenever you approach patients, including myself in the clinic, approaching patients about the idea of randomization here, it was not very palatable for them. They felt like, oh, I can just go to another institution, or, I feel like this might be something that would benefit me, so I don't want it to be randomized. I'm not comfortable with that. And those are all very reasonable and understandable, reasons to not, enroll into a study like this. As well as the physicians. I think that, this was one of the challenges that we encountered, from both the patient as well as referring physician sides. And so unfortunately, we were not able to demonstrate, the potential benefits of radiation. And this is a difficulty in general with randomized controlled trials for radiation, as well as other local regional therapies, LRTs. There are limited patient populations. Intrahepatic cholangiocarcinoma as a whole is already a rare disease. So studying it can be challenging. There's a subgroup of advanced biliary tract cancers, including intrahepatic, where there's competition with drug trials that are ongoing. There's different expertise at different centers, so that could include for radiation therapy as well as for other local regional therapies. The lack of equipoise is something that, I was mentioning on the previous slide, both for physicians as well as for patients. There's a perception sometimes that one is better than the other, and so the idea of randomizing is just not something that patients or physicians may be comfortable with. And that's very reasonable and understandable. There's also a difficulty in raising industry's interest in large clinical trials. This is a persistent problem, and it's one that we need to find a solution to. And then, of course, there's a necessity to take into account the heterogeneity of the population. This is kind of speaking to those entry criteria or eligibility criteria. You know, Unresectable intrahepatic cholangio as well as advanced metastatic intrahepatic cholangiocarcinoma. It could be unifocal, multifocal, unilobar, bilobar. This extrahepatic spread can be very limited versus very extensive. And then we spoke about the molecular heterogeneity. About 40% of patients with intrahepatic cholangio have targetable mutations, and have a different prognosis than those who do not have targetable mutations. So these are all things that, kind of make it challenging to do randomized controlled trials. And it's one of the reasons that NRG GI-001, was not able to go forward. So there are opportunities here. And this is what I really want to kind of engage your audience, the audience here, and, also be open to many ideas that you guys might have. So there are no randomized controlled trials for radiation in intrahepatic cholangiocarcinoma that have been completed. GI-001, as I mentioned, was closed due to poor accrual. The group in the UK has completed the ABC07 study, but that was largely for perihilar cholangiocarcinoma, which is considered extrahepatic cholangiocarcinoma, not intrahepatic cholangiocarcinoma. So a different disease grouping. About 80% of those patients in ABC07 were extrahepatic. The evidence for intrahepatic cholangio has been encouraging but limited. There's just been one single arm phase 2 study. There have been single institution as well as retrospective reviews, as well as large databases with limited clinical data. There's also heterogeneity in the studies. So we talked about patient selections. We need biomarkers, ways to identify patients who are going to benefit from radiation or not. We're not there yet, unfortunately. And we can have heterogeneity in terms of the inclusion of patients who have the spectrum of biliary tract diseases, so intrahepatic, hilar, distal cholangiocarcinoma, as well as gallbladder cancers. These are all different cancers. They have different molecular profiles, different prognoses, different ways of managing them up front. And so that can introduce, a challenge in interpreting the results. And so that comes back to, again, the emphasis on randomized controlled trials in specific disease populations like intrahepatic cholangio that are focused and really try to get at a very singular question, such as the role of radiation, for example. So what is all of this experience that I was, kind of alluding to up to this point? Largely, this began with our retrospective experience from MD Anderson. We looked at 79 patients, a median size of tumor was 7.9 centimeters, and the span from 2002 to 2014. There was good follow-up of all these patients over that time frame, and the key result was that the median overall survival for the patients who received radiation in this group was 30 months, and we saw a 3-year overall survival rate of 44%. And the single most important prognostic factor in this retrospective study was their dose of radiation. So the higher the radiation dose, that threshold again of 80.5 gray BED or biological equivalent dose, that was the key determinant of a better outcome. You can see here, 73%, at 3 years versus 38% at 3 years with a lower dose of radiation. That p-value was statistically significant, less than 0.05. The local control, so how likely was that tumor that we radiated likely to grow, was also statistically significantly different between the two groups at 3 years. Okay. We followed that retrospective study up with a prospective phase 2 single-arm proton study. Okay. So Massachusetts General, MD Anderson, and UPenn all participated in this. We enrolled patients with hepatocellular carcinoma as well as intrahepatic cholangiocarcinoma, and the sample size was, calculated to demonstrate a greater than 80% local control rate at 2 years. These were the eligibility criteria, basically no disease outside the liver, no prior radiation, and a maximum tumor size of 12 centimeters, and a good, liver function, which is what this criteria is speaking to. We used 15 fractions for these patients, and they received one of two doses, whether it was peripheral 67.5 gray or central 58 gray. So these were the approaches with therapy that we did for these patients. And the key results here were that there was a low rate of radiation-related toxicity, 4% grade 3 or more. And these were the things that happened for patients. They had a high bilirubin. There was one patient who got an ulcer. There's one patient who, demonstrated liver failure, but this was not a severe liver failure. There was a grade 3 or lower liver failure, which means that, temporarily and reversibly, they had some signs of liver dysfunction. And then one patient developed ascites or fluid in their abdomen. Okay. These were the overall survival results for hepatocellular carcinoma and intrahepatic cholangiocarcinoma in the yellow. So you can see like there's a nice tail to this curve, and these patients with intrahepatic have a more guarded prognosis, but these were actually the most striking results at the time in terms of overall survival with a local regional therapy like radiation or any other local regional therapy, ablation, Y90, for example. Okay. The local control was also excellent. At 2 years, the local control was 90%. And this was also, a very landmark finding for patients at the time. And that's what led to the GI003, or sorry, GI001 study that I mentioned earlier, which again, unfortunately, given these results with overall survival and local control, it was challenging to convince patients to enroll and randomize, as well as their physicians to allow them to do so. So these studies, really establish a foothold for radiation therapy for patients with localized unresectable intrahepatic cholangiocarcinoma, as well as, for that matter, HCC. Okay. Now, we followed that prospective study with a series of retrospective studies from MD Anderson. One of them being, for patients with molecularly characterized intrahepatic cholangiocarcinoma and radiation. So 150 patients, 113 of them who had next generation sequencing or molecular characterization. And you can kind of see the spread of, different genes that are altered in these patients that we looked at. And the key result was that the median overall survival, so, at the point at which half of the patients had passed away and the other half had kept on living on, the median survival here was 20 months after radiation, which was, quite encouraging in this molecular era of radiation. We did look at different prognostic groups and kind of, intuitively as an oncologist, we kind of know that certain mutations are associated with worse prognosis, and that kind of bore out in this particular study as well. Patients with TP53, ARID1A, IDH1, and FGFR2 were the most common, and they had different prognoses, given the limited sample size that we had. We still could see that there was some suggestion of a different survival rate as well as local control rate whenever we did radiation for these patients. So this could be important for selection of patients for radiation. Now, we've also looked at this modern era. So many of the studies that I was speaking to were done whenever gemcitabine and cisplatin were given to patients as a standard of care systemic therapy. Now, with the chemoimmunotherapy with either gemcis durvalumab or gemcis pembrolizumab, we actually don't know what is the profile of radiation therapy in this era now. And so over the past couple of years at MD Anderson, we've been continuing to treat with liver-directed radiation. During this, 2021 to 2024 era, we had 28 patients who received that, as well as radiation, the chemoimmunotherapy and radiation. And we found that there was a low grade, acute side effects that were very common. So that included fatigue and nausea. And then other things like pain, in the right side of the liver, diarrhea to some extent, constipation, thrombocytopenia, low platelets, some dermatitis. Those were other low-grade side effects that we observed in these patients. But there were no high-grade acute effects. So grade 3 or higher are considered to be high grade. Grade 5 is death. So we did not fortunately have any of that. So these were all low grade, grade 1 and grade 2. And most of them were grade 1 in this particular study cohort. As far as late effects, so things that happened months after the radiation, one patient did have hepatic impairment that was graded as 2 and possibly related to radiation. One patient had inflammation in the lungs, pneumonitis, that was grade 3 and likely related to the radiation because it was close to the bottom of the right lung. These are similar in their profile and what we would expect with prior reports in the gemcitabine cisplatin era without the immunotherapy. So really the take-home point here with radiation in the era of chemoimmunotherapy is that patients seem to tolerate the radiation very similarly, and there's nothing unexpected that we've seen so far with the 28 patients that we've treated in this retrospective study. We've treated more patients since then. We've also done a multi-institutional retrospective study of radiation for intrahepatic cholangiocarcinoma, and this is something that's sponsored by the ICRN or International Cholangiocarcinoma Research Network. This has been a collaboration amongst multiple, really, nice academic institutions. So we really thank them for all of their collaboration. This spans 17 years, and we harmonize the data collection. And the key result here is that we've seen, really nice median overall survival numbers here, 32 months, with the use of radiation and chemotherapy, and the progression-free survival, the time for new disease or growing disease was 19 months in this, which are really quite striking and, encouraging signs that, across multiple institutions, we're seeing reproducible results as far as the role of radiation. You can kind of see the distribution in this pie graph amongst all the institutions where MD Anderson contributed many of the patients, but we had significant contributions from all the other ones as well. So now the question is, okay, in patients who have unresectable, localized within the liver intrahepatic cholangio, there seems to be some benefits to radiation. We're seeing prolonged survival times. But for patients, whenever you have disease outside the liver, as pictured here, so for example, like in the bone, in lymph nodes outside, well away from the liver, maybe in the lungs, or even multiple satellite lesions within the liver, what is the role of radiation? And we looked at this in this publication that was published in 2023. We know that 20 to 30% with intrahepatic cholangio have M1 disease at diagnosis, and their chemotherapy and immunotherapy is the standard of care, as we've mentioned. Here, we looked at patients who just got chemo alone. This was in the previous era, with gemcitabine cisplatin was the standard. And we looked at the time to liver progression as well as, match these patients up to see, if there was maybe some prognostic factors that might account for differences that we observed. Because for the patients that received radiation in this study, there was about 61 patients who got radiation in this retrospective study. We just focused on the major, dominant lesion within the liver for the radiation, and did not treat disease outside the liver, for the most part. Um, there were some patients who had disease that was multifocal, so it was on both sides of the liver, and we needed to just focus, otherwise it would be too toxic to treat the entire liver here. And then we tracked again, the time to liver progression as well as their survival. And the key results was that the patients in this retrospective study who received radiation therapy appeared to have a prolonged survival. The median survival here was 21 months compared to those who just got chemotherapy alone. And whenever we looked at all the other prognostic factors, chemotherapy duration, the age of the patient, and their performance status measured by the ECOG performance status scale, those all associated with the prognosis of the patients along with liver radiation. And so this really speaks to a potential role of radiation just to the liver in patients who, by standard of care, and as we saw in the NCCN guidelines, is not necessarily considered a preferred approach whenever it comes to patients with advanced intrahepatic cholangiocarcinoma. So that leads me to this. We want to demonstrate and change clinical practice and improve the standard of care for all patients, not just the ones who come to MD Anderson. So we have a clinical trial that we're partnering with the Cholangiocarcinoma Foundation called Hyperion CCA. This is a phase 2 trial of chemoimmunotherapy with or without liver-directed radiation therapy for patients with advanced intrahepatic cholangiocarcinoma, where again the standard of care is systemic therapy alone with chemotherapy and immunotherapy. Radiation therapy is not considered to be standard of care in this setting, especially just focusing on the liver tumor by itself. This is a superiority designed randomized phase 2 trial of 126 patients. We will have an interim analysis after 50% of the required events. The primary endpoint here is overall survival, and we have key secondary endpoints: quality of life, progression-free survival. These were all designed with input from, Melinda as well as Juan Vale and Stacy Lindsay from the Cholangiocarcinoma Foundation as patient advocate representatives, giving us the patient perspective and just making sure that we're designing this in a way that hopefully will be, palatable to both physicians as well as patients, if they're considering, the option of this trial. They are expected to have a minimum of 4 cycles of gemcitabine, cisplatin, and durvalumab. And then they'll be stratified by these different prognostic factors: the duration of systemic therapy before they are randomized, 4 versus greater than 4 cycles, and the extent of disease. So here we're primarily focusing on patients with extrahepatic metastasis from intrahepatic cholangiocarcinoma, but we are allowing for patients who have unresectable locally advanced disease as well. These patients are being randomized 2 to 1, again, based on feedback that we got from our patient advocates, as consultants for the design of the trial. And they're more likely, patients who enrolled, to receive adaptive radiation to the dominant central intrahepatic disease, followed by maintenance durvalumab versus maintenance durvalumab alone, which is the standard of care. Okay. So again, very special thanks to Juan as well as Melinda for their input on the design of this trial, which is now open at MD Anderson and will be opening up at other centers across the US soon. We designed this with multiple statistical considerations, listed here. Um, on the other slide for that retrospective study that we published in liver cancer for patients with advanced, iCCA and radiation to the liver versus the chemo alone group, we saw a hazard ratio of 0.45, which is actually a very strong effect size. 0.57 is a more conservative effect size to say, okay, this is the potential more conservative estimate of benefit of radiation. Okay. So that's a common way of approaching the design of clinical trials to say, okay, our retrospective study showed this, but there may be some caveats to interpretation there. We want to be a little bit more conservative so that we are properly powered statistically to answer this question of whether radiation is going to benefit the patients or not. So it led us to 126 patients that were needed for this to have 80% probability to detect the difference in the two arms. We have key primary endpoints of overall survival as well as secondary endpoints of liver failure and quality of life measured by the FACT-HEP, as well as progression-free survival, as I mentioned. We're going to do an interim analysis of these patients as well, once we get to 50% of the required events. So this kind of concludes my presentation. The evidence for radiation is growing, but we need randomized controlled trials to change the guidelines and the patterns of care in the US as well as across the world. There's not been any randomized trial that has shown a benefit of radiation, which is what's needed to really move the bar and change this for patients across the spectrum of oncology. So we know that radiation can be safely given to patients with advanced intrahepatic cholangiocarcinoma, both in the previous era of gemcitabine cisplatin, as well as in the modern era with gemcitabine cisplatin and immunotherapy. Radiation associates with prolonged overall survival in retrospective studies. However, this utilization of radiation has not increased over the past 2 decades in the US or the world for that matter. Largely because there's no randomized studies. We have to convince the skeptics, both from the physician side as well as from the patient side, that radiation, actually has a benefit here. Even with all of our data, there are caveats to the interpretation of retrospective studies, and we recognize that. And there may be some potential harms that we have not measured yet in our selected patient populations. And so there remains equipoise, this uncertainty about whether radiation truly is benefiting our patients, even with all the evidence that I've shown you today. So this is understandable, this utilization, in the past 2 decades within the US. But I think we can get there. And, that's where Hyperion CCA aims to demonstrate the potential benefits of radiation for patients with advanced intrahepatic cholangiocarcinoma. The one thing I should have mentioned earlier is that in this study, there is allowance for crossover. So let's say that you enroll and you get randomized to the standard of care, immunotherapy, chemoimmunotherapy arm with no radiation initially. At the time of progression, you are allowed to cross over and receive liver-directed radiation at that point. So again, that was kind of input that we received from our patient advocates, and we agree. This is something that would make it more palatable to patients to enroll because then they know that we could do radiation in the future if needed. Okay, so I want to end by acknowledging all the people who have provided input and supported this over the years. Many special thanks to our friends at Cholangiocarcinoma Foundation. They're amazing and it's wonderful to work with and it's great friends. So very thankful to them listed here as well as all the other staff. I didn't have enough space on the slide to thank everybody from there, but you're all of you who are not mentioned there are certainly I'm certainly grateful for what you guys are doing. MD Anderson Cancer Center, there are a number of individuals who have supported the research that I've shown here today, and are supporting the Hyperion trial as well. So I want to shout out to them and thank them for their support. at Johns Hopkins, University College of London, as well as Tata Memorial Hospital in Mumbai, India. We have some great collaborators, really engaged, radiation oncologists as well as medical oncologists who are helping us to move Hyperion, into the clinical trial setting and, helping to enroll patients. So really thankful to have these types of collaborations. And there will be others. We're really trying to engage others across the US and the world to help us to answer this question that's critical to move the guidelines forward and to move the bar forward for patients. And of course, our funding. Rising Tide Foundation, Varian, AstraZeneca, Siemens, as well as the NIH, they're all in some ways supporting the trial efforts as well as other studies that we're doing for cholangiocarcinoma, and it's making a huge difference by doing so. So really thank you all again for the opportunity to present what we have today with regards to radiation for cholangiocarcinoma. Really hope that we can get the support from the community as well as the physicians and patients to move this trial forward and hopefully benefit patients you know going into the future. So thank you again. Happy to take
No, thank
questions.
you. Yeah, thank you, Dr. Coy. That was very informational. You did a great job of explaining, and it's always helpful for me to have someone who can explain it in ways that patients can understand. So we appreciate that. I'll invite the audience to go ahead and put questions in the chat and Q&A. We got several during your presentation. I'm going to start with one that was emailed to us earlier this week. If targeted radiation is used on tumors, what is the likelihood of metastasis to surrounding areas?
Yeah, this is a great question. And our data retrospectively would say that the chances of it coming back either within or outside the liver after, this type of therapy radiation is about 50 to 60%, within the first 2 years after radiation. So there's a pretty high chance, more likely chance than not, that it's going to come back somewhere. Um, most of the time it comes outside the radiation field, inside the liver. Okay. So you get new satellite lesions that pop up, and so we have to either zap those with radiation again, or ablate them again, or treat with chemotherapy, or some other targeted drug subsequently. Depending on the situation, it really depends on the status of the patient as well as whether there's disease elsewhere and what that is doing. So there's a higher chance than not that it's going to come back. So radiation by itself is not a cure, but as I've tried to communicate today, it could prolong and kick the can down the road, prolong life as well as kick the can down the road, and that's kind of the principle that we are trying to advocate here.
Yes, perfect. Okay. Is radiation therapy same or similar to targeted therapy?
So it's different. Targeted therapy traditionally is a drug that you either take by mouth or by an infusion that goes after a specific molecule on the cancer or inside the cancer or surrounding tissues. So that's traditionally what targeted therapy is thought of as. Radiation therapy is targeted in the sense that it's spatially targeted just to the tumor. So we're using the imaging and all that technology to really focus the beams of radiation targeted to the tumor that we want to treat with the high doses of radiation. So you could think of radiation as the original targeted therapy, but it's not targeting a specific molecule. It's targeting a specific area in the body where the tumor is.
Perfect. Um, have there been recent studies on proton versus standard radiation therapy? I think you already covered that.
Yeah, it's a reasonable question. I mean, we are actually doing that for hepatocellular carcinoma. That's the more common liver cancer. There have not been randomized studies to compare protons and other radiation therapies for intrahepatic cholangiocarcinoma, though.
Okay. And then has there been any studies to look at radiation protocol of treatment every day for weeks at a time? Does that make sense?
So the one study that I mentioned with the multi-institutional proton study, that was, one that we did a kind of regimented, 3-week course of radiation. I'm not sure if that's what the question is getting at, but there has been that one, and of course we're doing the Hyperion study now.
Okay, perfect. And can you explain use of carbon ion technology compared with radiation therapy?
Yes. So Carbon ion is another form of radiation therapy delivery technique. So it's a particle, the carbon ion, and they accelerate it, near the speed of light, and it goes in and deposits, the radiation energy to kill the tumor. Okay. Um, it's similar as proton therapy. Protons are, basically a charged, hydrogen, nucleus. Okay, so we're accelerating those to the near the speed of light, and it's treating the cancer that way, similar to the carbon. Um, Carbons and protons have a similar kind of dose distribution. If you remember back to that image I showed you of the dose distributions on the CT scans of the radiation, carbon ions have a similar sort of dose distribution where it will stop, after it's gone through a prescribed depth of tissue, and there won't be any other radiation exposure. It may have other differential biological effects than protons, as well as conventional X-ray radiation. That remains to be, borne out in terms of clinical outcomes for patients, as far as I know so far. There's not been any randomized trials to really show that for cholangiocarcinoma or any other, cancers for that matter. Those are studies that are ongoing, and maybe in the coming years we'll see that. But to date, right now, it just remains kind of another form of radiation, largely that they're doing in Europe and Asia. There is a carbon center that's being built in Florida right now, but there's none, that are actually online in the U.S. right now, as far as I know.
Okay. Okay, thank you for that information. I'm going to ask this question, even though I think you addressed it with the crossover. With patients who have multifocal disease within the liver, it sounds like you are just focusing on the primary tumor. If a
Mhm.
person enters the clinical trial and stops all systemic chemo, is that leaving that patient vulnerable with the other tumors within the liver? Also, could you speak to the one arm that is receiving only durvalumab, which seems to show low success rate? It seems those patients could at least benefit from other direct liver therapies such as Y90 or additional systemic therapy, which would leave them less vulnerable in the control arm.
Yeah, those are great questions. As far as like the vulnerability, this is always intended to be kind of multimodal treatment for the experimental arm with radiation. So we're not just doing radiation to the primary tumor by itself. It's the radiation plus the chemoimmunotherapy, which is the standard of care.
Right.
So we're not letting you fly without a parachute, so to speak. You're going to still get systemic therapy to maintain and treat the remaining other lesions that we do not radiate, especially outside the liver. But even if there are ones inside the liver, those, have been shown to actually respond to, chemoimmunotherapy and even maintenance durvalumab alone. I've seen that in my own clinic, myself. So there is still treatment. And, if the patient does progress eventually somewhere or develops new lesions somewhere, yes, at that point, they can move on to additional lines of treatment, including additional radiation or, ablation or targeted therapies. As far as the standard of care arm, again, like it has shown that there are long-term survivors with that approach. So I wouldn't necessarily characterize it as ineffective. There are some patients where it can be quite effective, and you may not need radiation therapy. That's why there's still a need to convince the community and to do a randomized trial. Certainly there are patients who do not benefit from it, definitely acknowledge that. And this is where we built in that kind of guardrail. You're allowed to then cross over and get radiation therapy if needed. And again, at the time of progression, there is allowance for the patient to get standard of care next line therapies, drug trials or other, as needed. So we're definitely taking all that, into account. This is kind of a selected patient population, and this is one of the reasons why we built in those 4 cycles of chemoimmunotherapy also initially. You
No
know,
kidding, yeah.
yeah.
And so this is a frontline trial, a first line trial. So the
Yep.
next question is, if patients have already started on maintenance durvalumab, what is the role of radiation?
Yes. So in those situations, they would still be eligible. So we built into this that you have to have at least 4 cycles. So if you're already at the point of maintenance durvalumab, you'd still be potentially eligible for this as long as all the other eligibility criteria are met. You'd just be stratified as having received more than 4 cycles. And so the randomization would be the same. You would get either liver-directed radiation followed by maintenance durvalumab, or continue on to maintenance durvalumab, as standard of care. So that would be still very acceptable as inclusion for the treatment.
Okay. We have a lot of questions. I'm going to try to get to as many as possible.
Okay.
How does this compare with Y90 radioembolization via SIR spheres for multifocal intrahepatic tumors?
Yeah, the answer is we don't know. There's not been any randomized trials to compare Y90 to radiation therapy. The best that we can do is just kind of take the studies that have been published for each one of those modalities and then just look at, the endpoints that were measured. Most of them will report overall survival as the main endpoint. But there are other endpoints that, as I mentioned, such as progression-free survival and local control, of the tumor that you treat. Those are other endpoints that are critical to understand the efficacy of the treatments. So with Y90, our friends, Julian Edeline, who's a colleague of mine that I collaborated with at one of the CCF meetings recently, they've published some very nice data that suggests that, the effect of Y90 in selected patient populations actually is somewhat comparable to radiation therapy outcomes as well. But again, they didn't measure all the same endpoints as what we did with radiation. And so it's hard to compare them apples to apples, really. This remains to be an area of research need.
Okay. Um, any experience with low volume isolated lesions like Klatskin tumor, no molecular markers of benefit, no evidence of metastatic disease, ablative radiation therapy with radiosensitizing dose of capecitabine? Um,
Yeah.
a GI physician with interest in CCA is asking.
Yeah, this is a good question. The ABC07 study that I mentioned briefly during the talk was 80% or so extrahepatic cholangiocarcinoma, including these kind of, perihilar Klatskin tumors. That one was a 5-fraction SBRT radiation, dose, which is, slightly different from what I was talking about with 15 fractions and, that BED of 60 gray or 58.05 gray. So, um, that's a different biology. Extrahepatic cholangiocarcinoma does not have as many targetable mutations. We really don't know, honestly, what the, effect of radiosensitizers like capecitabine might be in that setting. Our practice has been to try to deliver as high of a dose as tolerable and use concurrent capecitabine because, we know that, from experience that it's safe. But there remains a need, just like for intrahepatic cholangiocarcinoma, to define the role of radiation. I do know that the cooperative groups, NRG is actually developing a concept around this. And this is one that we'll be reaching out to you, Melinda, to give us feedback on in the near future.
Sounds good. And I think you touched on this in your presentation, but do you believe patients with targeted mutations respond to radiation more favorably? I think there was a certain subset that you had
Yeah.
data on.
Yeah, that was that molecular study that I was, referring to earlier. We had about 150 patients, a subset of them had next generation sequencing, and we did see that patients with FGFR mutations as well as IDH1 mutations had different prognoses than those who had more aggressive mutations like P53 and ARID1A. Those had more guarded prognoses, but still actually seem to maybe have a different profile that you might have expected if they had not received radiation. So yeah, it's a differential prognosis, but there still may be a benefit in all situations. It's just that the effect, with those different subpopulations may be different, if that makes
And
sense.
you'll be collecting that data in this trial as well. Yes.
Absolutely.
Okay. How common are radiation-induced biliary strictures in patients where the hilum is included in the radiation field?
Yeah, it's a good question. So we developed our dosing regimens based on data that came out of Japan. So for biliary strictures, whenever you exceeded this threshold of about 72 gray in 14 fractions with radiation, in this Japanese study. There was a relatively high rate of biliary strictures, about 5%. In our studies with the proton study, particularly, where we gave either 58.05 and 15 fractions to central tumors or 67.5 gray and 15 fractions to peripheral tumors, we did not see any biliary strictures. And those BEDs, the biological equivalent doses with that fractionation, those doses, was below the threshold dose that the Japanese study identified as, higher risk for biliary stricture. That said, in our larger studies, these retrospective studies that I presented today, we have seen a few biliary strictures. I would estimate that the rate of stricture formation after these doses that we're talking about is about 1% or less. So
Okay.
it happens, but it's not very common.
Could the HAI pump be combined with some sort of radiation therapy?
It's a great question. We would love to do a clinical trial on that.
All right, we're just lining them up. We're just going to keep getting all these trials started so we can figure out all the
Right.
answers.
Yeah.
Um, uh, I'm trying to get the ones that aren't so personal, and then afterwards we'll try to come back to some of these and get these questions answered. We're a little bit over, but if you can stay one more minute, I'll ask a couple more.
Yeah, I've got time.
Does location of the lesion in the liver limit the ability to apply radiation? For example, the dome of the liver, can lesions in the dome be treated with ablative radiation or protons?
Yes. Our principle here is to deliver as much dose to the surrounding organ tolerance. So regardless of where it is, if it's right next to the stomach, for example, the heart, the esophagus, the bowel, we cover as much of the tumor with the ablative radiation dose. And then with all those technologies, we can have a dose fall off where that dose of radiation is safe for those other structures. So we know from experience, biliary strictures, for example, that there are dose tolerances that we cannot exceed. That includes for the bile ducts, but then also for all the other structures, heart, esophagus, stomach, bowel, the liver for that matter. So as long as we are safe with the surrounding normal tissue structures and the doses, and we cover the primary tumor to as high of a dose as possible, to as much volume of that tumor as possible, that's what leads to the outcomes that I've shown you today.
Okay, I will end maybe with this question and then gather up all the other ones and see if we can get them answered somewhere down the road for everyone. Um, Can radiation therapy be useful to turn an unresectable tumor into a resectable one, changing mass characteristics?
That one we don't quite know. Um, there has been experience with preoperative radiation therapy for gallbladder cancer. There's also been studies that have looked at preoperative or sorry, pre-transplant radiation therapy as kind of a bridge to therapy for hepatocellular carcinoma. Those have all shown a nice effect of radiation therapy for those other types of liver cancers. I'm not aware of a very good preoperative radiation therapy study for intrahepatic cholangio. Um, it has been used for patients with extrahepatic cholangiocarcinoma as well. So in all those settings, extrahepatic cholangio, gallbladder, as well as for HCC, hepatocellular carcinoma, radiation has been shown to be safe as a preoperative regimen before some type of surgery, whether that's resection or transplant. And in the transplant studies for HCC, it actually shows a high rate of complete responses. Like there's no viable cancer left, which is what you want at the time of a transplant, because otherwise there might be lingering cells at the time of the transplant that might metastasize and come back even after the transplant. So you could extend that principle to cholangiocarcinoma, given that we're seeing high rates of control, with these ablative doses. It's really just a matter of, selection of these patients, if needed. Um, a lot of the times the radiation can complicate a liver resection. And so for intrahepatic cholangiocarcinoma, especially whenever the surgeon can get it all out and they can do the surgery pretty quickly, there's probably not a need for radiation therapy preoperatively. But for extrahepatic cholangiocarcinoma and gallbladder cancer, where those can infiltrate along the blood vessels and the bile duct systems and other things nearby, doing some radiation to kind of sterilize the field of surgery for those types of cancers, I think oncologically and just kind of from first principles makes more sense, because there the surgery, as complicated as it might be, is not going to do the patient much good if there's any cancer left behind. And that's the principle of trying to do multimodal preoperative therapy, before resection. You want to try to help the surgeon get everything out. Whereas with intrahepatic cholangio, it's not as often that you need to do that because the resections can just get the whole part of the liver that the tumor is involving out of the patient's body. There's some exceptions to that. I mean, those some of them can be infiltrative just like the other diseases I mentioned, but by and large, it's not the case. Yeah.
Okay. Thank you so much, Dr. Coy, for your time and for answering all the questions. And we're going to gather up all those
Pleasure.
questions that didn't get answered and see what ones we can get answered and send back to or
Be
put out
happy
there
to
for you.
help.
And then for any of you guys who have questions about the trial, you can reach out to Dr. Coy at MD Anderson, or you can reach out to the foundation and we'll make that connection as well. But appreciate your presentation and thank you for taking the time and thank you for doing the research for our patients. We so appreciate you.
It's my pleasure, and thank you for the opportunity again.
Yeah. All right. You take care and have a wonderful
Yeah.
day.
You
Thanks,
too.
everyone.
Bye, everyone. Thank you.
Bye-bye.